Hey everyone, my name is Mark. I'm one of the cardiology fellows. Spencer is another cardiology fellow who's behind the camera. Today we're going to go through just demonstrating keys to image acquisition of a point of care ultrasound of the heart. We're going to use this dummy here, and I'll just walk you through some of the basic views and how to kind of optimize them for whatever you need to do. And Spencer will ask me questions as we go. Okay, so we're going to start in the parasternal long axis. So one thing to keep in mind is that all of your transducers have this, what's called an indicator. Sometimes it's a bar, sometimes it's just a little dot at the end of the probe. This indicator corresponds to the dot that is on your ultrasound screen, so you know that that is the same side as where your indicator is. So it's one thing to keep in mind when you're starting to acquire your images. So as I said, we'll start with the parasternal long view. So that just means we put the indicator probe on the patient's chest. It's the left parasternal space, and you want the indicator pointed towards the patient's right shoulder. It's about the third or fourth intercostal space. So I put my indicator probe on, and what you can see on the screen is it's all just black. That's pretty common. That's basically a consequence of what we call rib shadowing. So that just means that the probe is right over a rib and we can't see anything behind the rib. So all that I do to fix that is I slide the probe up or down. So I'm going to slide the probe this way, and we can see if that fixes the image quality at all. So you start to see something come into view. So there we have a heart, and that's a pretty good view of the parasternal long axis. But what I'm going to do is I'm going to tweak it just a little bit, because you can see this is the left ventricle here, and I'm a little bit off axis. So what I'm going to do is I'm going to twist. I'm going to keep the same position, but I'm going to twist the probe so that the indicator points a little bit more towards the right shoulder, and we'll see if that fixes the image at all. Looks a little bit better now.
What do you mean by looks better?
So one thing is that the different, what I can see as far as the left ventricle, and the mitral valve and the aortic valve, the leaflets are a little bit crisper, and I can see their motion a little bit clearer. The other thing is that I'm going to turn it back to where it was before. There was still a little bit of rib shadowing there in the other one, and do you see the left ventricle here? It's not really fully, we call this foreshortened. This just means that I'm kind of cutting, maybe you can see here better. I'm cutting through the left ventricle so that I can't really see the whole thing. If I twist it to elongate the whole ventricle, I can see it a little bit better. And you can almost see, from this view you can't see the apex, but you can see more of the left ventricle here. The other things to keep in mind are the depth. So I'm going to switch hands here. The depth here is actually pretty good. You want to make sure that you can see the entire posterior wall of the left ventricle, the posterior wall of the left atrium. This is the descending thoracic aorta here. It'd be nice to see maybe a little bit more of this. So on these machines, you just click on the depth, and I can drag this up or down, so that makes it zoom in more. This makes it zoom in less. That's probably a reasonable view. When you have the actual ultrasound machines, it's just a knob that we'll show you on a separate video. And then the other thing to keep in mind is your gain or your contrast. And so really what you want to do here is you just want to optimize it so that you can actually see the structures of interest best. So you can adjust, this is the gain, and this is the contrast. If you have it way up like this, it's almost too bright. There's too much contrast and there's too much gain, so it's almost distracting from what you're actually looking at. Where we had it initially was probably reasonable, but I think just knowing that these are things that you can tweak and adjust is useful. You kind of know what's comfortable for your eyes to look at.
There is a function called auto gain or optimization that most of the machines have that you can use to get optimization based on the computer algorithm.
You just press the button and it makes it look a lot better. Okay, anything else before we go to parasternal?
Show us the structures.
Yeah, sorry. So this is your basic parasternal long axis view. This is where we almost always start because it gives us a really nice outline of a lot of the different structures of the heart. So this here is the left atrium. I'll use the mouse. These leaflets here are the leaflets of the mitral valve. This is the anterior leaflet, posterior leaflet. This is the left ventricle. Oftentimes we'll see these little things in the left ventricle that you're not really sure what they are. This is a papillary muscle. We'll see that a little bit better in the short axis views. So that's attached to these mitral valve leaflets. We just can't see all the structure because it's out of the plane of the ultrasound. And then this valve obviously then is the aortic valve, and then this is the aorta coming up here. This structure that's on top is the most anterior chamber of the heart, remember, because this is the ultrasound beam coming from the top. This is the chest wall of the patient. So the thing that's closest to the ultrasound is the most anterior chamber, so that's the right ventricle of the heart. So you have right ventricle, left atrium, mitral valve, left ventricle, aortic valve, aorta. This is the posterior wall of the heart. This is the descending thoracic aorta. This patient, in this view at least, doesn't have a pericardial effusion, which we would see as fluid collecting posteriorly. It would collect between the heart and the descending aorta.
And fluid is black.
Fluid is black, yeah, thank you. And a pleural effusion, you could also see sometimes in these views, that also collects posterior to the heart, but it would be posterior to the aorta here, as opposed to a pericardial effusion, which is between the heart and the aorta.
So that's why Mark earlier had changed the depth to be able to see the aorta, which can help with the pericardial effusion versus pleural effusion question.
Exactly. Okay, anything else before we switch here?
Nope.
Okay, great. So we're in parasternal long view now, so now I'm going to switch to the parasternal short view. So all that we're doing is we're going to rotate the probe about 90 degrees. So now we're going to start to cut the heart in the short axis view like a loaf of bread. So I'm keeping the exact same position of this probe, and I'm just going to very simply turn.
So notice how he
90
uses
degrees.
his left hand while keeping the probe in the same place with his right hand. So that's a great way when you're first learning to rotate the probe like he did.
Exactly. And so you can see I did move a little bit because there's a little bit of rib shadowing on that view. So again, I'm going to do the same thing. I'm just going to slide up or down a little bit to try to get that rib shadow out of the way. Hopefully not make it too much worse. That's okay. Let's see if we can get it a little bit better. Maybe here or so is kind of reasonable. We still have a little bit of rib shadowing, but we can see for the most part what we're interested in here. So we're kind of down. We're now cutting the heart in the short axis, as I said. We're below the level of the valve, so we're just looking at the left ventricle here, the right ventricle here. The left ventricle obviously is a very circular structure here. The right ventricle is this kind of crescent-shaped thing that hugs around the left ventricle. And all that I need to do from here, since this is a good view to look at multiple things, you can see effusions from here. You can look at wall motion, but I can also look at the mitral valve and the aortic valve just by very simply scanning up and down the heart. So all I'm going to do, if I want to get towards the apex of the heart further down, then we know the apex is further down here. So I keep the same position of the probe, but now I'm just manipulating the tail. So I'm going to tilt it if I want to get to the apex this way to get closer towards the apex of the heart, and I can get all the way out to the very tip of the heart.
So that's tilting or fanning.
Yeah, exactly. And then if I want to, I can tilt or fan back up towards the mid portion of the left ventricle and right ventricle.
So here in the mid, at the mid-papillary level, which we had seen previously, go back down, mid-papillary level, the interventricular septum is muscular, and so you get a good sense of the function and wall motion if that's necessary for you. And then he's going to keep going up to the mitral valve. So that's the fish mouth view of the mitral valve that we had seen, looking for mitral valve pathology.
Keep going up. Let's see if we can. Sometimes you might have to slide up a rib space.
So you can see coming into the middle of the view is the Mercedes-Benz sign of the aortic valve. So this is the parasternal long again, but just tilted or fanned more towards the base of the heart.
Exactly, and then there are some other, I'm going to try to fix this a little bit just because Okay, hey everybody, so we're back. We just got finished doing the parasternal long axis view and the parasternal short axis view. So now we're going to do our next one, which is the third of our 4 views, the apical 4 chamber. So again, we have our ultrasound probe here. Here's our indicator that lines up with the dot on the screen. I'm going to take my indicator and probe, and I'm going to put it, kind of try to find right the apex of the heart. So a lot of times that's kind of the mid-clavicular line, often just below the nipple, and the indicator is pointed towards the patient's left. So this is where I kind of landed here. This is not a bad image. We can optimize it a little bit. So the first thing I'll say is that my depth is a little bit off because I'm cutting off part of the right atrium here. So I'm just going to go in, click on depth again. Maybe I won't, because this is the depth is already optimized. So we're cutting off a little bit of the left atrium, of the right atrium, but it's fine. We can see the ventricles just fine. The other thing I'll say is the left atrium, left ventricle are the center of the screen, which is okay for looking at the left atrium and left ventricle. If you wanted to look at the right ventricle, then I can swing the image by dropping down the tail of my probe to include more of the right ventricle, which is over here. I'm just going to drop the tail down, and you can see the image swing so that the right ventricle gets more towards the center of the screen. So this is a reasonably good view that we have here right now. You can see both ventricles. A couple points, because it can be a little bit confusing as far as which ventricle is which sometimes. I know you can use the indicator, but we sometimes forget. In a typical normal heart, the left ventricle should dominate the apex. So that is the ventricle that reaches the apex. The other thing is that the left ventricle, again, in a normal heart, should be larger than the right ventricle, which it is here. And then if you look at the mitral and the tricuspid valve should always be closer to the apex than the mitral valve. So because the tricuspid valve is closer to the apex here, I know that this is the right ventricle, this is the left ventricle. So things we're focusing on in this view, just kind of broadly speaking, one is, what is the left ventricular ejection fraction? And just grossly, above or below 40%, 50% is a good thing for us to be able to eyeball here without making specific measurements. Two, what is the size of the right ventricle? So when we eyeball it, the right ventricle should be about 2/3 the size of the left ventricle or smaller. If it's the same size as the left ventricle, it's probably enlarged. You can actually measure the right ventricle during various phases, but we're not going to get into that during this video. And then three, looking for pericardial effusions, again, is a good thing to do from this view. Obviously, pericardial effusion would show up as fluid, so black on the echo screen, and then be surrounding the heart on the outside. We can't see the posterior walls very well in this, the posterior portion of the heart very well with this view, just because of our depth is limiting. But that's really it for the apical 4 chamber.
Can you show us a foreshortened apical 4?
Yeah, for sure. So what Spencer is saying is that a lot of times when we put the indicator probe on, we might have the probe angled in kind of a funny way, and so you might see something like this. I'm going to try to tilt it without getting the ribs in.
He's just too good.
That is definitely not true. Let me try. Actually, let's do this.
Perfect. That's exactly.
This is kind of okay. Well, it's not okay. This is kind of the foreshortened view. So what's happening basically is, and again, I think it's a little bit easier if you look on this 3D screen, is the ultrasound probe, the plane of the probe, is basically clipping a portion of the heart, and it's making it look like the heart is like collapsing with every heartbeat, and it's basically overestimating your left ventricular ejection fraction. So it's creating, in a way, kind of an artifact to lead you to believe that the function is better than it is. So what you want to do is really make sure that you're opening up as much of the ventricle as you can, and you do that just by making really slight, small adjustments so that you can see as much of the ventricle as possible.
And another way to assess whether you're foreshortened is what is taking up the majority of the apex. And so, as previously mentioned, the left ventricle should make up the apex. If the RV is making up the apex, then you know you're foreshortened.
Okay, we are back again. So this is the last of our 4 views here, we're going to do the subxiphoid views, and along with that, we're going to look at the inferior vena cava, the IVC. So, and to review, we already did peristernal long and short and the apical forechamber. So for subxiphoid view, we go subxiphoid. So again, here's our indicator that's pointing towards the patient's left. Can't feel rib space too well on this guy, but we just put the probe down. And what you want to do is do your best to try to get all 4 chambers included here. You're kind of angling, usually it's at about 45 degrees and back towards the heart. And you'll get this kind of off-axis view of the 4 chambers of the heart. And just so we all know what we're looking at here, this is the right atrium, tricuspid valve, right ventricle, left atrium. This is the mitral valve, left ventricle. This is a reasonably good view to, again, if you're having trouble in other views assessing the left ventricular ejection fraction, it's always a really good view. It's also a really good view to look for pericardial effusions. And then this is the view that we use to get to the IVC to assess for collapsibility. It can be helpful for volume status, etc. And honestly, this is oftentimes a good view to use if you're having trouble getting peristernal or apical forechamber views, especially in patients who are intubated or who have a lot of pulmonary disease, because you're going around the lungs rather than going through them.
There's no rib spaces to contend with.
Exactly. Okay, so to go from here to the IVC, what I'm gonna do first is I'm gonna try to center the right atrium in the center of my image here. So here's the right atrium, and all that I do is I kind of swing the tail of the probe this way so that the right atrium's in the center of the screen or so. And then what I want to do is I want to get the IVC running kind of horizontally through the image. So the way that I'll do that, we all know that the IVC runs on the patient's right vertically and the aorta runs on the patient's left vertically. So I want my indicator to be in the long axis of those vessels. So I'm gonna bring the tail of the indicator up, and I'm gonna turn the probe so that the indicator is pointing towards the patient's head. And then all I'm gonna do is I'm gonna tilt towards the right to get in the IVC. And I can bring in the right atrium a little bit more there. So that's the IVC.
How did you bring in the right atrium more?
Good question. So one thing to remember is the indicator is up here towards the patient's head. So I know that my indicator is up here on the right of the screen. So if I want to bring more of this stuff into the image, I'm going to slide towards the indicator. That's towards the patient's head. So I'm going to slide it up this way, and you can see the right atrium kind of comes into the screen more and more. Now I'm getting into ribs, but
so that was movement of the whole probe, and then also, is there a way to tilt?
Yep, exactly. So
rock the probe.
Yeah. So one thing that's really easy from this view to do is to flip back and forth between the IVC and the aorta. And all that I do for that, right now I have the IVC in view. I know that the aorta runs kind of in parallel with the IVC, just on the other side. So all I'm going to do is tilt, instead of facing towards the patient's back right, to his back left, like this, and there pops in the aorta. And I can go back and forth between the two. It's really important to identify both structures here because it's very easy to confuse one with the other. When you're imaging the IVC, you have to confirm that it's the IVC by watching it empty into the right atrium. Otherwise, you can very easily confuse it with the aorta. And if you're measuring sizes of the IVC and you call the IVC diameter what is actually the aorta, you can misinterpret and give not helpful or false information.
You can misassess or inappropriately assess their volume status by calling the wrong vascular structure.
Exactly. So that is IVC into right atrium, and then if I tilt the probe left, we can see the descending aorta.